Hi everyone, and welcome to our presentation today, Grounding HIV, HCV, and STBBI Treatment and Prevention Within First Nation Cultures, a Community-Led Reciprocal Learning Approach. Before we start, we respectfully acknowledge that we are presenting on Treaty 6 territory and the traditional lands of the Métis, and in the east of Newfoundland on the ancestral homelands of the Beothuk and Mi'kmaq. My name is Rachel Landy, and I'm a postdoctoral fellow with the Drum and Sash project that we'll be talking about today. And here is my colleague.
Hi, I'm Carrie Lynn Lund. I am Métis from Edmonton, living in Edmonton. I coordinate the Drum and Sash project.
Here is our conflict of interest disclosure. Now we'd like to tell you about our work.
Drum and Sash actually builds on the Aboriginal Community Youth Resilience to HIV project that SIA Canada led back in 2005. And this is, the communities, 3 of the original communities joined us for Drum and Sash. And the important things that we want you to know about this is truly a community directed and a community engaged project. We don't give opinions and try to lead it our way. This really comes from the community, and it's grounded in the Indigenous language and culture. Community readiness assessments with evidence-based interventions was how we started, so that people knew where they were coming from. And so also community-specific action plans, including prevention and harm reduction, screening and linkage to care. All of this was based on the findings of community readiness, so that they knew the kind of language and the approaches that would make it safe to look at HIV and hepatitis C in their communities. And available to them as a way of support is a large team, 40 plus people on our team, of experts that include academics with related expertise, clinicians, and other health professionals, as well as a broad range of community and regional support services.
So one of the first activities that we have facilitated and engaged with our partner communities has been to do the community readiness training. And this community readiness training can be used to address many different types of issues. It's a series of questions that communities ask within their community to find out the readiness level on a given topic. And in this case, it was on HIV. And so from this training, from implementing this tool, communities could assess if they had a lot of knowledge or if they didn't have any knowledge, and how much stigma was affecting their ability to address issues around HIV, hepatitis C, STBBIs, and other sexual health issues. So this was our first step, engaging with communities, and they identified their own priorities from the findings from their community readiness assessments. And these priorities were really around addressing the knowledge needs within the community, and addressing stigma, both within the community as well as within the organizations and institutions in the community, such as in the health centers and other workplaces. And then they also identified a need for more training and capacity building opportunities. And from there, they have sought opportunities through organizations like KP8 to learn more about HIV and hepatitis C, and also around anti-stigma or reducing stigma within their communities. And they also identified the need to develop more community-specific resources, including for STBBIs, as well as for COVID and how COVID-19 has affected STBBIs in their communities.
This was also an excellent opportunity for community to work with the clinicians that are in the urban centers that are partners on the project to look at their institutional stigma and to reduce practices and ways of doing things that were uncomfortable or stigmatizing to people coming in. So as I said, this project is grounded in culture and language. And so what an elder had shared, his word of wisdom to us, was the reason why people are not engaging and not responding to the coordinators in the communities trying to work with them and increase knowledge and their engagement, was because HIV and hepatitis C had no place in their culture. It was viewed as an outsider type of thing that they didn't relate to, or they were afraid of it. And so the elders' advice was create a place in the culture for it, and people will respond. And so we did this with, we supported communities to do this using community appropriate protocols and developing new protocols. We met with the Stoney Nation elders first, and there were absolutely humbling and incredible conversations that Rachel and I were able to observe and to support the discussions. They at first were extremely hesitant, very uncomfortable. If any of you have worked with elders with their hands crossed and their heads down, you know it's a sign that you're going to have a challenging time to get them engaged. Rachel actually showed them a video of work that she's done in the East where elders made a video, which was really a great way of showing them that other elders are dealing with this. But by the end of the day, they had actually come up with stony words for HIV and hepatitis C and other words to help in talking about sexual health in a way that was easier on the ears for them. And they were excited and they wanted to go and tell other elders about it. And very much the same with the Blackfoot elders. They expressed great concern and past trauma, past experience with disease that had come from the outside in. And they, again, were very hesitant to talk about freely, especially with the genders in both of these communities. Men and women do not talk about sexual things, but they rose to the occasion, and the richness of their discussion and the words that they came, and particularly the protocols on how to go forward are invaluable to the safety and the success of their community work.
So one of the really great findings or really great opportunities that has come from the work that we have collaborated on with different communities is the opportunity for reciprocal learning, where we're learning as much as anybody else is learning, and within our community engagement and all of the activities we do. And one of the things that's really important to know is that every community is different, and all the protocols are different, and the ways that people engage with people working in their community and coming to collaborate is different, and the difference is something to be celebrated and learned about and acknowledged in all of the activities that we do. Another key thing around this reciprocal learning is that this project has given us an opportunity to learn how communities do research, their own research, and how they learn, and how this has changed over time, and where information comes from, and how elders seek information, and for instance, and how they communicate that information to their other fellow community members, and including, we're doing some work with elders and youth, and this is a really, really exciting way to learn as a researcher how to engage in a good way and learn about the ways that research is being conducted within communities by community members. Again, also, go ahead. Yeah.
Well, I was just going to add in that many researchers go into community and assume that, other than academic and researchers from institutions is the only research that has been done. But there is Indigenous research that has happened and has been shared in stories since the beginning of time. And a lot of the teachings and protocols and ways of knowing and doing come from that research and come from those stories where the knowledge translation is done in stories and continues to be done. So actually learning about those Indigenous ways of doing research and how their knowledge translation is most successful. And again, with the youth and the elders coming together, the youth being able to do their research and sharing it with the elders and back and forth is creating new protocols. Very exciting. So one of the other things is that this is also a learning experience for the clinicians and their teams. So they have community members come into their clinics and shadow and learn what goes on there and develop relationships so that when they pick up the phone and talk, they've got a relationship that they know this person and they know what goes on, and they can talk to the person seeking services about their experience there, as well as the clinicians come out to the community and sit with community and hear what's important to community and the kind of services and the way that those services are provided. It helps them to do a better job in what they do as well.
Just a few of our findings or a few of the stories we wanted to share about what we've done in our work so far in collaboration with First Nations communities in Alberta.